For our next talk on challenges on organ transplantation, I would request the presence of our distinguished chairpersons on stage. Dr. Rohit Gupta sir is a renowned and senior gastroenterologist of our city. Dr. Sapan Srivastav sir is a renowned, reputed oncosurgeon in Kamla Nehru Memorial Hospital, Prayagraj. And Dr. Shirish Mishra is associate professor in Department of Urology, Motilal Nehru Medical College. I would request our speaker, Dr. Sonal Asthana ma'am, to join us on stage. Sorry. Sir is a reputed liver transplant surgeon in Bangalore. I would request our chairpersons to introduce our speaker.
Good afternoon, ladies and gentlemen. You can read his biodata, his CV, but the real introduction for him is that he was my transplant surgeon, and I got operated by him, and I'm hale and hearty now, thanks to him. And I was delighted to be under him, and I'm fit and fine doing my work. So that is his introduction. People, thank you Dr. Asthana कि प्रोसीजर अब हो जाएंगे, रोहित वापस आ गया. Dr. Sonal.
Thank you. Thank you, Dr. Rohit. Thank you, Dr. Dr. Shukla, for the very kind invitation. It's a pleasure to be here in such august gatherings, and this is the best IMA hall I've ever seen, and I've seen quite a few. I must congratulate you. This is amazing work. So when this topic was first given to me, the topic read challenges in transplantation, and by nature I kind of don't look at challenges as challenges. I look at challenges as opportunities. But that's because I'm naturally optimistic. I'd like to start this talk by asking, how many of you are optimistic people? Even today, Hamas has invaded Israel, terrible times, right? Are you optimistic people? Okay, about half. So this is a tough crowd. I hope I can convert you by the end of this talk. Okay, the talk's topic is liver transplantation reasons for optimism. I'm actually glad that I follow Dr. Sheshagiri Rao's talk on and the last question. I mean, can India afford things like this? You know, can India afford something as expensive as transplantation, or a moon mission, or a Mars mission? What does India gain? The gain is not in dollars and cents. The gain is not in helium-3 that we may bring back, much as it may be good. The gain is in the inspiration that ignites in people. And I hope that among the people who are listening today, I can convince people that transplantation is a worthy alternative, and hopefully inspire somebody sort of younger than ourselves to consider this as a career, and that would be an afternoon well spent. These are my current appointments. I do not have any financial or competing interest in this talk. So of course India has a long and abiding relationship with transplantation. Our mythology starts with the transplantation of an elephant head onto a baby boy, and that's the god that we invoke before we start anything auspicious in our world. So Ganesha's head being transplanted is probably the first recorded or history in Indian mythology, and this is also matched by a lot of other contemporary mythologies. Of course, this is something closer to our heart because it has one very basic biological fact. Does anybody know who this person is? I know it's the post-lunch session, so I thought I'll ask a few questions. Okay, this is Prometheus. This is the person who stole fire from the gods to give it to the human beings, right? So as a punishment for this, he was chained to a rock. So during the daytime, an eagle would come and eat up his liver, and at night, the liver would grow back. So the significance of this particular story is that even the ancients realized that the liver has regenerative potential. Even if you remove part of the liver can regenerate. When we look further into mythology, this is again early Christian mythology, there's records of a limb being transplanted from a soldier, from a slave. You can see that the soldier is fair-skinned and the slave's leg is black-skinned. And this is something that has been recorded in Christian mythology as well. So what do these things have in common? There is a desire to obviously inculcate some attributes that are considered to be desirable. In Ganesh's case, it was obviously essential that he has a head of an elephant. And this is a chimera, which is another mythological beast which has the head of a lion, the body of a goat, the tail of a serpent, which has perhaps the best attributes of all these beings. And this is what transplantation aims to do, to replace something that is diseased with something that is better or perfect. So despite our sort of fascination with transplantation as a species, the first successful transplant was done in 1954 in recorded human history, almost 70 years ago, by Joseph Murray, between identical twins. When one kidney was taken from one twin and transplanted into another twin, the person lived for 8 years after that. Dr. Joseph Murray got the Nobel Prize. He was the last surgeon to do so. Surgeons don't normally get Nobel Prizes, but he was probably the last one to do so. The first liver transplant was attempted in 1963 by Thomas Starzl, and it was first technically successful in 1967. But it wasn't till 1983 when we had good medicines to suppress the immunity, the anti-rejection medicines, cyclosporin, that transplantation became the gold standard for end-stage organ failure. The first successful liver transplant happened shortly after. Split liver transplant followed later, living donor transplants, and these have relatively recent histories. This is probably the two most important figures in transplantation, in liver transplantation, that is Tom Starzl and that's Dr. Roy Khan, and both of them receiving an award because Dr. Starzl described the procedure of a liver transplant and Roy Khan discovered cyclosporin. So without these two working together, transplantation would not be possible, and that is probably again a central theme. Transplantation doesn't work with one person. Transplantation needs a team. How successful is transplantation? This young girl was transplanted in 1970 by Tom Starzl. You can see she's quite yellow. She had biliary atresia. 6 months later, the yellowness is cleared. She was fair-skinned, and this is her picture in 2016. So she's alive and well 46 years after a transplant. So transplants can last for a very long time. What about India? India actually was not far behind when we talk about transplantation. The first transplant was attempted by Dr. Mukherjee in KEM Hospital in Mumbai in 1965. That did not work. The first successful kidney transplant happened in 1971. We just recently completed 50 years of transplantation in India. We had to wait for our law to be passed in 1994, which recognized brain death as death. So as you know, there are two kinds of death. One in which the heart stops, that we all know and we recognize as interns, we declare death, day in and day out. There is another kind of death, when there's a complete cessation of brain functions. There is a loss of circulation in the brain, after which no life is possible without support. Such patients are found in ICUs, they're on ventilators, but the circulatory system is intact. So that means that all the organs are getting perfused. When patients who are identified to be brain dead are counseled, then some of them can be potential organ donors. This was actually put in place in India in 1994, and since that time we've actually had multiple laws, multiple iterations of the law, and the program has now become quite successful. We currently are the third largest program in the world, doing almost 3,900 transplants per year. So why are we optimistic? Firstly, we are much more standardized in who needs a transplant now. There are a lot of technological advances in organ support as well as in surgery. There is a standardized system of skill development which is so essential for surgeons. There is better data available. We have an Indian liver transplant registry, and more importantly, we are working on ways on making sure it's accessible to more people. So what are the indications for liver transplantation? The most common indication for liver transplantation is decompensated chronic liver disease. We can do liver transplant for acute liver failure, which is a dramatic presentation, usually because of poisoning or viral causes, in which a transplant has to be done in a short period of time, a 10 to 12 hour period. Children sometimes suffer from metabolic disorders and need a transplant for single gene defects. Liver cancer can also be cured by transplantation. And of course, there are systemic complications of chronic liver disease. So when a patient presents with cirrhosis, this is usually what happens. They have chronic liver disease. Most people are fit and well. They do not have any external symptoms. They have compensated cirrhosis. Something happens after that, usually a bleed, development of ascites, development of an infection, let's say an SBP, encephalopathy or kidney failure such as HI and hepatorenal syndrome, which is actually the balance tipping. That's balance tipping from compensated to decompensated cirrhosis. And after which actually if it's not treated, then death follows shortly. And this decompensation is what decides when someone needs a transplant. So all cirrhotics who are stable do not need a transplant. They can actually be followed up on medical management. But when you have decompensation, a bleed, development of ascites, and how much of the left lobe has to be taken out, how much of the right lobe would remain. And so we know that we would take out about 540 ml and leave about 850 ml, which is 60%. So this was obviously a very safe operation to do, and the child did well. We can take this forward. We can use the CT scan image to actually create a 3D rendered model. We print out the venous structure. We can cast the liver in silicone, and then this we can actually use it to perform the operation itself. So in order to do a surgical planning, this is something that we can do. And when we take it one step forward, we can use virtual reality. This is something that we've been developing. I'll just come here, save time. So we've been developing this. So you can see that you can take a liver model. Yeah, and you can separate out. Maybe I'll just let it play. Yeah, that's the liver. So this is again made by CT image. You can pick up a knife, cut into the liver. It's quite easy, isn't it? Pick up the liver, separate it out, take the sample. So if you want to plan anatomy, move the model around in your hand in virtual reality, this is possible. And this is not technology of the future. This is available today. We can do this now. So when we take out the liver, we can separate out not just the liver part here. That's the spine, that's the venous anatomy. So when we go here, for example, it's possible for us to take out, the hepatic venous anatomy, the whole liver here. This is the hepatic venous system. And that's the portal venous system. So you can actually take it out and study it in a virtual reality model. We have mixed reality models as well, in which this can be imposed onto a CT scan or onto an anatomical field. So for that we plan it better. That's what a cirrhotic liver looks like. You can see that there's a tumor right at the bottom. That is what a deceased organ transplant looks like. So you can see that this is a pale organ. That's the celiac patch. That is the portal vein, and we are preparing to sew this in. What do we do in a transplant? We first do an anastomose the IVC, we anastomose the portal vein and the hepatic artery. The IVC is normally anastomosed by a side-to-side anastomosis, the donor IVC and the recipient IVC. We normally use an end-to-end anastomosis for the artery. This is usually microvascular. This is done under magnification. So that is the recipient artery, that is the donor artery. You can see that there is a size mismatch, but you can actually join these two together. And this is what it looks like at the end. You can see that the artery and the vein are joined, and the liver has become a nice and a pink color as opposed to the pale color you saw before. So this is what a perfused liver looks like. You can see the liver on the bench, very pale, and after reperfusing it becomes a healthy pink color. And this is a very heartening thing as a transplant surgeon to see. The dissection that we do for a cirrhotic is to remove the portal structures here. This is the donor hepatectomy and a living donor, where we clamp the portal vein. We achieve a line of demarcation that tells us where to go, where to divide the liver. When we take out the liver, we have to do what is called bench preparation, where we attach vascular grafts to portal vein as well as to the middle hepatic vein, so that these can be joined up. That's what it normally looks like. This liver is ready to be implanted. One thing that of course stands out is the patient survival getting better. So after all these survivals that we do now, era by era, we have shown an improvement in survival. Now the survival at the end of 1 year is almost 90%. But the real action is taking place at the right of the graft. So among patients who were transplanted in the 85 and 89 era, 50% are alive 15 years after the transplant. So you remember the last talk on oncology, right? We do not talk about 5-year survival. A person who's had a transplant is expected to live 10, 15 or a whole life after a transplant. That's how long a transplant lasts. Of course, now we've done a lot of technical modifications so that we use more organs that were previously not usable. Some of the modifications here are reconstructing the entire middle hepatic vein. You can see what we have created, what is called a neo middle hepatic vein, using an iliac vein graft from a donor. We do an intraop ultrasound scan just to make sure that all the vessels are patent. If we have patients who have a technical issue, like this donor had 2 portal veins, we reconstruct that on the bench and we use the prosthetic graft. We can always use other prosthetic grafts to achieve extension of the vessels so that these vessels are amenable to joining. Other vascular techniques such as using bridges and fences also allow us to reconstruct what was actually unfavorable vascular anatomy and make it favorable. That is a vein patch being put on right hepatic vein so that we can actually use that for anastomosis. This makes the anastomosis very easy. Again, sometimes the IVC itself is infiltrated. We can fashion an IVC out of bovine pericardium into a cylinder. And in some children where you have an atresia of the portal vein and the vena cava, as you can see here, the main portal vein is really a thread. You can actually use a venous graft to reconstruct the vena cava as well as a jump graft to reconstruct the portal vein. So this was done for a 5-kilo child. We can also increase the donor pool. One organ can be split into 2 parts and given to 2 patients, one adult and one child, which is called a split organ transplant. So we can actually, by these innovations, we can increase the number of organs that are utilizable. In this situation, we used a split and a domino together, so we were able to utilize one organ to actually save 3 people. Again, one thing that has improved is our reliance on technology. We use less blood than before. We have been doing bloodless transplants now for the last several years. Now, in transplantation, they used to be identified by streams of blood coming out. In fact, they used to say in training that how do you identify transplant OT, because their blood will be coming from below the door actually. That was the amount of blood usage. But nowadays our median blood usage is approximately 2 to 3 units per transplant. We are also better at preserving organs. So now you know that when we take out an organ, we flush it with a preservative solution so that the organ can stay cold on ice and we can transport it and then implant it into a patient. The organ can be preserved outside the body for 6 to 8 hours. Now, depriving an organ from circulation is not a good thing because the organ obviously suffers what's called ischemia reperfusion. So now we have a machine that allows us to perfuse the organ with blood, with oxygenated blood outside the body, which is called normothermic machine perfusion. So this is an organ, you can see it's a very fatty organ, right? It's been connected to the machine. You can see what happens once we start to perfuse it. So blood flows in. You can see the color of the liver change here. So this is the reanimation of the liver. Okay. And immediately the things that we normally see for viability of the organ, it's not very clearly seen. You can see that there is bile coming in that plastic tube. So as soon as the blood starts to circulate within the liver, you can see the liver pinks up, becomes healthy, and bile starts to produce. So this technology can be used to preserve the liver for longer periods of time. This, of course, improves the ischemia reperfusion injury, and this is the organs that are transplanted are much healthier. Coming to the last couple of things, I shall just skip over a few things. There's a retrieval workshop that we conduct so that we can train people in the skills of retrieval, organ retrieval. This is done in Bangalore with frozen cadavers. We've trained more than 200 surgeons now in organ retrieval. And the last part is models of service delivery and access. You certainly need a very large team to do this. We have a large flat team that covers several hospitals, and that has allowed us to perform these surgeries in a standardized way across many, many centers. The last part of what I want to talk about is expanding access. So what is the point of doing something that 99% of the country cannot afford? If there are the skills, if there is the technology, then there has to be a way of making sure that patients can get this kind of treatment. This is something that is particularly acute to us for pediatric liver transplantation. We think that 2,000 children need a transplant every year. Less than 50 to 60 get a transplant every year. The survival with a transplant is 90%. The mortality without a transplant is 90%. So there's a very clear reason to transplant. There's a clear need to transplant. And for children, we know that there's a single gene defect. They can benefit from a transplant. Most parents are happy to donate part of their liver. I mean, in that position, I would do as well. And the only problem is the money. We know that children do very well after a transplant. One of the first people to be transplanted, this girl was transplanted at the age of 11 or 12 because of acute liver failure for Wilson's disease. Mother in this picture was the person who donated, and this is her picture on a phone call. She's at college now. So we know that when we do a transplant effectively, children can do well for a very, very long period of time and become healthy human beings. So how do we make sure that children get transplanted? So this child, father donated, father drives on Uber in Bangalore, got a transplant for a hepatoblastoma. This actually story started for us with this particular girl called Ashwini. She presented to us with acute liver failure, which is very dramatic. We have to do a transplant in 48 hours. Her father is a factory worker, earns 7,000 rupees in a factory in Bangalore. So she came, we didn't know what to do, we transplanted her. And then we realized that there's a lot of money to be organized. So at that time we started making phone calls and reaching out to people for raising money. It was a very steep learning curve for us because we realized that this child needs a transplant, and luckily for us, it was a happy ending. She did well, and we were able to raise money. But this identified a pain point for us. What does a transplant cost? In India, the cost of a transplant is the least in the world. So we talk about the cost of a transplant in India. There's no place in the world that does a transplant as cheaply as India. And this is India's sort of primary USP, isn't it? We put a machine on the moon for less than the cost of a movie to put a movie on the rover on the moon. So we do things extremely cheaply. The problem for us, why is it so cheap in India? Of course, because we use a lot of innovation. We use new technology. We use split liver expertise. We do bloodless transplants. So that these are all things that have developed within India that have actually driven the cost down. The problem is not the actual cost of the transplant. The problem is in the patient's availability to pay it. This study actually was done in PGI Chandigarh, in a government hospital, to do renal transplant in the richest state of the country. 50% of people actually had to sell property. So the problem is not, even if it was 1 rupee, there were people who would not be able to afford it. The correct question here is, what does the patient pay? Again, we talked about this. Can India afford transplantation? It competes with a lot of other things. But we thought that it's actually a worthwhile initiative because there were people that we could help, and children should have access to transplant regardless of their economic status. So we found a mechanism by which we reduced the cost from 25 lakhs to 2.5 lakhs. How do we do that? We created a funding model where we use some money from the patient, some money from crowdfunding, and some money from CSR funds in order to do this. CSR, as you know, is now ratified by law in India. It has the potential to generate quite a lot of money, almost $4 billion US, and it can be utilized for healthcare costs as well. So we have some CSR partners who identified who help us, and this is basically the flywheel in which it works. The patient pays 2.5 lakhs, we raise money from CSR, from crowdfunding, and then we rely on the hospital to provide some subsidized drugs. Social media is a double-edged tool. We know that can't live with it, can't live without it these days, and India is a very high consumer of social media. India tops the world in Facebook users. We know that everyone on Facebook. Well, what is the positive that we take out of this? If every Indian on Facebook paid 220 rupees per year, that is 11 rupees per month, then we could fund the entire Ayushman Bharat scheme. Okay. So when we talk about Boon Boon Se Sagar, this is exactly what it means. If we are able to leverage our social media presence in a positive way, we can actually pay for Indian healthcare. So that is not an unachievable goal. So that is why Tanmay, who you saw earlier, he required 18 lakhs for his transplant. We were able to raise it in 4 days using a crowdfunding platform. The number of donors is many. There are almost 1,600 donors per campaign. The average donation size is very small. It's only 2,000 rupees. But with that small amount, we are able to raise this money. Currently, we have done about 187 pediatric liver transplants in the last 5 years. We've raised almost 12 crores. We have a survival comparable to the best in the world. This was actually taken up by IIM Ahmedabad as a case study for using crowdfunding, helping patients by raising money for philanthropy. This is actually available on the Harvard Business Review as well. So what have we done so far? We've transplanted about 700 odd patients. Most of them have been living donors. Quite a number of them have had deceased donor grafts. A large proportion of our work is cadaveric transplant, and we have an 88% survival at 5 years. Successful, I think it depends on how you define success. So this is a picture that one of the children drew for us when she was discharged. I think I look a little bit better than that, but that was a good effort. I think this is, I value this above many other things, including awards actually. So of course, it takes a team. We have had a big team that's been together for several years. Without a team, this doesn't work. We can always say what Ash said, start where you are, do what you can. But it's probably better to end with a quote from somebody from Allahabad, a senior Bachchan, right? Harivansh Rai Bachchan. He said, hai andheri raat, par diya jalana kab manaye. Many thanks.
Thank you, Dr. Asthana, for such a nice and informative presentation in the liver transplant. Sir, 2 questions, sir. First, तो Dr. Sonal Asthana belongs to Allahabad. इनका ननिहाल यहाँ पे है, so that is a very good thing for us. The first question is why we are not developing this transplant in the northern part of the India.
This absolutely, when we look at it right now, none of the reasons that are actually quoted are actually true. So when we talk about capital or infrastructure, the government is spending crores on infrastructure. There are so many private hospitals that have got infrastructure that are better than most hospitals in the West. So we have the techniques, we have the skills, we have the capital and infrastructure. All that is needed is the will. At this point, I think that the responsibility is squarely with the medical professionals, actually. Because our traditional ways of working, where we have sort of one leader and many people working under them, does not apply in transplantation. Transplantation needs a lot of people to work together in a harmonious team, and the captain doesn't even have to be the best player in the team. It's not cricket, it's football. So we have to understand that putting together teams, multidisciplinary teams, is probably the first thing that we need to do to deliver transplant effectively. The second is societal support. Transplant is one of those things that does not occur in isolation. Unlike, say, cardiac surgery, neurosurgery, you need donors. Unless the society is convinced about the need for donation, it's educated about the need for donation, transplantation cannot happen. And society would get convinced of the need if the persons who donate have access to transplant. So it's a bit of a vicious circle, because unless you do transplants for non-affording people, you're not going to get a situation in which your community is going to support you with donation. So I think that it's a solvable problem. It has been solved in other parts of the country. There is absolutely no reason why it can't be done here.
I think the neurosurgeons should take a lead, because they are the ones who can convince upfront the patients, the donors, to donate.
Second question, how much time it will take, the duration for the patient for the cadaveric transplant in your setup, either in other setup, because most of the patient don't have a donor. So I think the cadaveric transplant is the best for.
So actually the time is very variable. It depends on the blood group of the patient. Obviously, if blood group O, etc. which are very common blood groups, have a long waiting list, they tend to wait for longer periods of time. You know, little uncommon blood groups like blood group AB, it is uncommon, but what it means is that even if there is one donor, there are probably fewer recipients for that donor. So they wait for a shorter period of time. So there are several factors that determine the time on the waiting list. Blood group is one of them. Size of the patient is another. So if you have a patient who's only 50 kilos, then they can only a smaller donor will work for them. So they tend to wait on the list for longer. So on an average, most people are waiting, are getting organs within 3 to 6 months of waiting.
Thank you, sir.
I would now request our President, sir, Dr. Subodh Jain, sir, to felicitate our speaker.